Hi, I'm John Cerrito, and welcome to this HTT special. My special guest today is the 18-year president of Overlook Medical Center. He has seen many changes. He's seen his industry evolve over the years and also innovate. His name is Alan Lieber.
John, it's great to be here. I'm really thrilled you invited me and looking forward to our conversation.
Alan, 18 years as president of a medical center, but it wasn't always a medical center and you weren't always there. Why don't you tell us a little bit about your past, your path, from the time you were young to the time you got to Overlook?
I'll be glad to do that. So I was born in Brooklyn, and then we moved out to the suburbs of New Jersey, came to Old Bridge, New Jersey when I was 6, and grew up there, had a great childhood, played a lot of sports. I was fashioned myself as a basketball player when I was 13. I was a big guy, and then I became a little guy, and that didn't work out so well. Played a lot of tennis and football and did a lot of things with my friends, was into music, and just had a great childhood in Old Bridge.
But from Old Bridge, Alan, you decided to move out of state for a while with your education. Where did you go to school, and what was the determining factor of choosing that school?
Yeah, so I went to Cornell, and it was a great place. I was a very good math science student, and so went into engineering, and had a couple of first choices, wound up having to choose between Cornell, MIT, and Duke. So MIT kind of fell out because the male-female ratio was 1 to 5, and they said you can meet women by going to mixers and other places in Boston, and I didn't think that was the healthiest environment to go to. And I just liked Cornell a little bit more than Duke, and so turned out to be a great choice.
Now, were you thinking when you were at Cornell, was there something specific that you were gearing your education to make a profession of?
Yeah. So like I said, I went into Cornell engineering and was trying to. You have to take math. You have to take your physics and calculus classes and chemistry, and then eventually you have to figure out what engineering to go in. In the back of my mind was always the potential to go to medical school. So I was taking pre-med courses and taking my engineering courses and trying to figure out what direction I'd go in. And then one summer I worked as an orderly in a long-term care facility, and it was an incredible experience. It was I wound up having to take care of 70 and 80-year-old incontinent men, and I was all of 19, 20 going through that experience. And on the one side, it was rewarding because I felt like I was doing something, but on the other side, I was like, if this is what direct service is, this is what being a physician is, it's like, yeah, I don't think I want to do this. So I really, at that point, was like, okay, well, let's figure out an engineering realm to go down. And majored in operations research and industrial engineering, which was a great background and a great discipline for problem solving. So I also became president of my fraternity. And I'm not exactly a fraternity guy, but I enjoyed the role. And it turns out it was really a management role because we had a house and I had a budget and managed the house, and we had a kitchen, we had a food plan, so there was this was like really managing an operation. And I really did enjoy that. And I bumped into a friend of mine on the big quad up at Cornell, and she shared with me that she had just applied to this health management program. And it was one of the things that just clicked. It was like, okay, you're interested in the medical field, you're interested in management, like, wouldn't you put it together? So I said, like, you're not supposed to make your career decision this easily, right? But so I thought about it for a week or two, and it still felt like the right thing to do. Turned out that Cornell had a graduate program in healthcare management in the business school. There were lots of other things that were great about it. My wife, who was my girlfriend at the time, was a year behind me, and so I was able to get into a program that allowed me to stay one more year at school and study something I thought I really wanted to do, which is health management.
So it was actually a double win for you.
It was.
Alan,
It was.
so again, you get into health management, you get into health care. We're going to fast forward a bit. You end up at Overlook Hospital here in Summit, New Jersey in 2003. And I must, for full disclosure, you've announced your retirement, which
Yes.
is going to take place in a few weeks.
Mhm.
And you've just done such a spectacular job, which we'll talk about later on. But how did you end up at Overlook?
Yeah, so I've spent my career this is probably the fifth or sixth place I've been. Most of the time I was at academic medical centers, and I had started in Virginia, was in Maryland, Hahnemann, and Philadelphia, and then I was working at Lenox Hill in New York City and running the cardiovascular program there. I got a call from a search firm, so God bless Korn Ferry. They called me up. They said they had a job being the lead administrator at a great suburban hospital in New Jersey. I live up in Bergen County, and I was like, okay, I get to run the place, and I get to do this in my home state, and I get to do this closer to my house. So it was another kind of, this one did not, I didn't need a week. This one, when it appeared, this was just a great opportunity for me.
But this opportunity came, Alan, but you mentioned something. It was Overlook Hospital.
Yes.
And again, we talked about it in the opening, how your industry, like many,
Yeah.
but especially healthcare, has evolved and has exploded into so many different dimensions.
Right.
What is the difference between a hospital and a medical center?
Yeah. So, I kind of think through these 18 years at Overlook, there's been two major evolutionary changes from when I got here in 2003. One is, and this kind of goes straight to the regional medical center. We very much were a community hospital when I got here, and we took great care of a fairly narrowly defined, geographically defined community, and it provided really good care, but hadn't grown in a very long time. I mean, I remember being a little startled when I looked at the 10-year financials that basically hadn't grown. In fact, it had maybe shrunk a little bit. And so we did set out to grow the business. And part of that was we treated patients from a broader set of communities. And I'll talk a little bit more about that. But we also built programs that drew patients from around the state and even from out of state. And so, for instance, when Union Hospital closed, we stepped in to run the emergency room. And we've now built that up so it's a hospital without walls. I mean, a hospital without beds. So we've got an imaging center there. We've got an infusion center there. We have rehab. We have large medical practices, large medical specialty practices. We now have an ambulatory surgery center that's there. And so with very few exceptions, you can get all the care we provide at Summit at the Union campus. And
Just not overnight.
just not overnight. And quite honestly, I think that community is better served. We provide higher quality care than was served when they had inpatient beds. And part of what would tell you that's pre-pandemic, we actually saw about 25% more patients come through the emergency department. So I think the community voted with its feet. They identified that we were providing higher quality care, and more people came to the ED.
Well then, Alan, would you say that the terminology medical center that we started to hear very much, 10, 12 years ago,
Right.
Was it because of multi-campuses or was it because of services?
Well, I think, so I think the bigger part of the regional medical center was building services that draw patients from a large geography. So we have the largest neuroscience program in the state, and we provide brain tumor services, stroke, spine, comparable to anything you can find in New York City. In fact, when people hear that a patient might be under the care of physicians at Overlook, and they go for a second opinion in New York, they'll often tell them, I can't do anything better than what you can get. So,
how did the helipad that went into existence a few years back impact the neuroscience?
So it was really, the reason why we did it was because we want to reduce the amount of time it takes for patients with bleeds to get to us, patients with strokes. By putting the helipad on the roof, they're going to come straight down. Ultimately, this is about shortening the amount of time, and it's very clear in the literature that time means brain. That the less time there is, the higher, the better chance we have of reducing mortality or disability, which is a big issue in many stroke patients. We, at the time, said we were going to see about 2, maybe 3 flights a week, and in fact, we're seeing 2 or 3 flights a week. And so we are able to get patients here from Hunterdon and from Newton. We get patients from Englewood, Holy Name, from other places in the state, and they do fly in. And it's all about time, and it's all about speed. It's also, it's one less transfer. Because we had patients flying here, we were just landing in Connell's office parking lot, and we had to have an ambulance go pick them up. So it was not built to be a helipad, and it added a whole other trip instead of now landing on the roof. But the helipad's also another part of how we've thought about care differently over time at Overlook. And one of the things we talk about is creating a culture of urgency around the patient. And so the helipad is just a very, very visible thing where we've tried to figure out ways that we can get the patient to care faster. Another example, also in the stroke realm, is we have a telestroke service. So we have essentially iPads that we can use to zoom in an expert to guide the care for patients so that we can, if they're eligible, we can get them from the time they hit the emergency room to get TPA faster. And that's a metric we use all the time. So we started looking at, I remember the team came in and said, hey, there's this new advance. We can put, they made CT scanners small enough to go into an ambulance rig. And people around the country, or a couple places, had started putting these ambulances with CT scanners in it. But I kept saying, well, okay, you could do that, but it's not going to, you're only going to treat a group of people in like half the county, and it's going to be real expensive because you got to put a rad tech on. So, like, yeah, we could buy it, but how does this work? So eventually the team went off and said, okay, we give Uncle, we're going to come a different way. And what they did is they started putting those iPad devices, basically cameras, into the ambulances. And so if there's a suspected stroke patient now, we start taking care of that patient before they get to Overlook. So the whole thing is to reduce the door to needle time, how long it takes from the time the patient hits the door till we start TPA. So if we can do the whole assessment, we just have to do a CT scan, and so we've done it in like 13 minutes. Now, we don't do that all the time, but we've gotten it down so we can potentially do it in 13 minutes.
And time is the most crucial thing
Right.
with strokes right now, and as you said. Alan, I'm going to name a couple services, maybe even some new equipment that came on
Sure.
during your tenure, and maybe you might be able to give us a brief description and how that has really enhanced healthcare. All right, and one that really interested me, and I had a chance to tour it, was the CyberKnife, the second generation CyberKnife.
Right.
What does the CyberKnife really do?
Yeah, so we put the first CyberKnife in the Northeast back in 2004, 2005. And what it does is it delivers very precise radiation therapy. And you're able to move the radiation source around the patient in many more degrees. So they miniaturize a linear accelerator. So typically a linear accelerator is about the size of this room, and patient goes on a fixed bed, they're on a gantry, and it rotates around them. And what they did is they miniaturized that source and they put it on a car robot. And so they move that source around you. And so why is that important? Well, what they're able to do is put higher doses and more, the computer does a simulation so they can be more precise. Where do you care most about that? Well, you care in brain tumors, because by being by being able to get more precise doses, they can spare the tissue around the brain and have less side effects. So that's been a key. Prostate cancer, we use it for prostate cancer because, again, you're worried about getting precise radiation to a patient's, to the tumor, but you don't want to hit the stuff around it, right? And we've also used it for lung, and they're starting to use it for pancreas. So there's starting to be some more applications.
So there's expansion to.
But it really is all about very, very precise delivery of radiation therapy.
And prior to these cyberknives, if they can do the surgery, is very invasive.
Yes.
Recovery time with cyberknife surgery?
Yeah. So CyberKnife typically is 4 fractionated treatments of radiation versus prolonged treatment of 30 or so. There are situations where they can use it for inoperative patients, which I think is what you're referring to. We've probably seen that more at lung cancer patients, where the surgeons can't get in for a variety of reasons, and so they're able to use radiation as an alternative.
I'm going to name a couple other departments. Bariatrics.
Yeah. So the bariatric programs, I'm going to make a bad pun. It's a very large, active, really high-quality program where it's been accredited for a long period of time. We probably treat, in a given year, 900 patients with bariatric surgery. And when we measure outcomes, we use there's a professional group called NISQIP, which is a group of surgeons who got together at American College of Surgeons and have defined what quality measures are. And typically, all of our quality metrics are in the top 10th percentile. So very proud of that. But what's really amazing is talking to the patients after they've gone through it, because it's really life-changing. And there's been going back even when I came here, bariatric surgery was out in 2003, and there were a lot of people saying, "Oh, we're going to come up with some sort of pill to replace it, or we'll come up with." They've tried pillows that they insert in people's stomachs. The bariatric surgery has really, over the last 18 years, continuously proved itself to be a very, very effective treatment. In fact, they're finding that it reduces diabetes in certain patients. And in fact, one of the kind of little known things going on with the pandemic is there's actually been an increase in patients getting bariatric surgery because BMI and weight is a factor people are worried about, right? So there's a heightened concern about that, and they've actually seen an increase in bariatric surgery nationally.
And I'm going to bring you into a different realm of medical care, and I know that it's very tough for hospitals to be everything for everybody, but we hear so much about psychological issues, depression, addiction, eating disorders.
Yes.
Overlook Medical Center doing anything to provide those services?
Yes, yeah. So we have a nice range of psychiatric services, from outpatient to IOP, so intensive outpatient, to we do have a 24-bed voluntary inpatient unit. We do a lot of work where we provide ECT therapy, which has proven to be very effective. I think when I was a kid, people were shocked. Shocking people was just horrific, but it actually turns out to be a very effective treatment for depression. One of the programs we've launched in children's services for us is adolescent eating disorders, and it is really one of the programs I'm most proud of. And Walter Rosenfeld's our chair of pediatrics, whose focus was in adolescents, and he really brought that to us. And we started with focusing just on adolescent children who have psychological problems around eating, so typically anorexia. And we've got it's largely an outpatient therapy program, and sometimes, unfortunately, they require inpatient stays, so we take care of them then. And we work in sort of cohorts of about 12 kids at a time, and people can come in and out. So we've had very good support from the community to help build that up. Unfortunately, time has gone on. We've actually found the need to do this for 8 to 12-year-olds. So a few years back, we opened up an 8 to 12-year-old program. And now with the pandemic, we're working really hard to expand this because kids took it on the chin. And it's tough to be an adolescent, and schools and schools disrupted. So we've been working really hard. We have a long waiting list, and we've been working hard to get more teams trained up so that we can expand that.
All right, my last question on services. It's something that every one of us has experienced at one point or another. I know it's a very difficult and challenging area to service the public. Obviously, the greatest complaint is the wait, no matter what medical center you go to. But tell us about what goes on in the ER, in the emergency room.
Oh my! So my first, the first ribbon cutting I did at Overlook was an expansion of the emergency department. And we've been doing nothing but expanding the EDs. We've either been opening new space or planning new space for my entire 18 years. And so we're about to do that again. We're going to open up a pediatric center where we integrate our pediatric ED with our inpatient pediatric department. And that will also, by moving the pediatric emergency department out of the adult, it'll actually give us room to expand. But yeah, it's a huge challenge. It's sort of it continues to grow. People continue to use emergency departments for their care. And, I would say one of the things that people often think is that it's people who don't have insurance, and it's not. It's you and me. I mean,
it has been.
And people, there's lots of different reasons people go to the emergency room. I mean, some people have figured out that, if they need more than one test, it's easier to go there and get access to X-ray and labs, and if they need a pharmacy, because everything's sort of right there.
When you say, though, the majority of people that use that, it's really a crisis situation.
Mm-hmm. We've seen over time, particularly the advent of urgent care centers, that the less acute patients typically go to an urgent care center. So yes, we see people who really do have emergencies.
Okay, Alan Lieber, I'm going to ask you some questions. We want to know what's going through your mind. I know the academic background, I know the technical background, but you know what? You're also the president of a large organization, and there are certain leadership qualities that are needed. What would you recommend, or what would you suggest, or what are your strong points that you feel as president of an organization like this that's made it work?
Yeah, well, now it sounds like an interview question.
It is.
So, so I've learned, there's a lot of things I've learned kind of along the way, and I've learned to try and listen really well to diverse thoughts, and try and encourage people to share. We were talking a little bit before. One of the little devices that we came up with during COVID when we're on Zoom was just sharing a Word document with my team so I can get all their thoughts really quickly on a couple of key questions, and be able to try and synthesize those into action plans. So I think one is just listening. We've had innovations that have come to us from staff members. We've had innovations that come to us from community members. We've had innovations come to us from physicians who have a burning interest in their field. So I think, to me, that's about, first thing is you got to listen. Second is you got to prioritize and sort out which things fit against your mission, and what can you make work economically so you can make it sustainable. And so I think having analytic skills goes back to my engineering background to kind of sort through multivariable opportunities, and then get stuff done. So you got to motivate people to
motivation.
You got to motivate people to get things done, and it's a combination of encouragement and being a good coach, and sometimes really kind of saying, okay, we've had enough discussion, we've got to get this done.
So it's multifaceted. Leadership qualities are do you have a leader that you admire? Did you have a mentor in your life, whether it be someone at the lower level of your life or somebody through the professional end?
Yeah. I had, well, there was an administrator early on when my first job at Medical College of Virginia, a guy named Jeff Yormel, who I learned a lot from. And there were a couple of other folks there that I learned a lot from right at the beginning of my career. And then Jeff went to Hahnemann, and I followed him, and have always just admired. He had a much calmer personality than I did when I was in my 20s, and I learned a lot about being calm and allowing yourself to listen from Jeff. But I've also learned from people who work for me. You know, I was just having this conversation the other day. I hired this respiratory therapist, and I had it turned while I was at Medical College of Virginia, and again, I was in my 20s, and I had to convince. It was a state facility. In order to get him the compensation package he wanted, I had to convince him to make him a faculty member. And then I found out he didn't have a bachelor's degree. He had an associate's degree. But he was running the respiratory therapy program at the Ohio State University. So I don't know how I talked him into it, but eventually we did. We got him there. And the truth was, he was a much better manager than I was. And I learned a lot from that guy. So.
Well, that's all good stuff. You know, Alan, the one thing that I've always heard about Alan Lieber is that his leadership is consistency in demeanor and the way you treat people. You certainly have gotten the most out of so many people. You know, we're going to take a really short break right now.
Okay.
We're going to come back. We're going to talk a little bit more about some of the things that have happened during your 18-year tenure there. And of course, recently we'll talk about the pandemic and how we all dealt with it. So we'll be back in just a moment.
Named one of the world's best hospitals by Newsweek and one of America's 50 best hospitals by Healthgrades, Overlook Medical Center provides superior care for Summit and communities throughout Union and Essex counties. With national certifications for stroke care and spine surgery, a comprehensive epilepsy center, a neurointensive care unit, and a team of specialized neurologists and neurosurgeons, Overlook Medical Center has proven itself to be a regional leader in neurosciences. It's also home to the region's highest volume CyberKnife program in the Carol G. Simon Cancer Center, as well as a comprehensive breast center whose team brings extensive knowledge to its cutting-edge care. The region's leading physicians, nurses, and professional staff at Overlook Medical Center are dedicated to making a difference in the communities they serve. Overlook has safety measures in place so you don't have to delay your care. For more information, visit atlantichealth.org/Overlook.
Welcome back to this special with Alan Lieber from Overlook Medical Center. And Alan, you know, part one was so interesting to hear the opportunities and the services and the changes that you have seen over the 18 years at Overlook Medical. But, you know, there's been a lot of innovation, a lot of creativity that you've encouraged from staff, from nurses, whomever it may be. Can you share some of those things?
Yeah, so you know, I think I'm very proud of all the innovation that has gone on at Overlook, and I really think it's part of our culture now and will continue to be. And you can put it in a lot of different buckets. We talked a little bit about the CyberKnife before. So we've been very much on the forefront of technology, which creates tools to take care of patients. And so CyberKnife's a great example. We put a 320 slice CT scanner, a super fast CT scanner to help the stroke program. Then that one worked great, so we put in a 640. And all of this, and we had the courage, we had the staff who was very comfortable like putting in things that are new, innovative, and allow us to create tools to take care of patients. We've had doctors participate in a number of clinical trials. Several of them have been in the neurosurgery realm, where they're developing new devices that retract clots or create new devices that take care of aneurysms. There's a trial right now called the MIND trial. We're the leading enroller in the world of patients in that trial. Our vascular surgeons have been participating in using laboratory-grown cellular tissue for valves and using those as, instead of plastic, as a way to have longer lasting valves that they use for vascular patients. So those are all things we've done, and we've had some phase 1 trials in oncology. PDP trials. So all of these things are different approaches we've taken to offer the community the very best care. And we've had the courage to do that. But the thing I get the most excited about is ideas that either the staff came up with on their own, just because we pointed them in the right direction and said it's okay to experiment, or even things that have come to us from the community. So I have some props here to talk about what we get from our staff. So this is what we call a blue bag. And the material is this really heavy plastic blue wrap. And what do we do with this blue wrap? We wrap surgical instruments that we are putting into an autoclave. We're sterilizing. We put the blue wrap on to protect the instruments. We put this little white tape just so you can see it's authentic. And when it goes in, before we put the autoclave on, it goes up to 300, 400 degrees. It's all white, and then it turns black, so we know we print it. But the big problem is this is really heavy-duty plastic, right? And this goes to the dump. And we put 12,000 pounds of this.
After one use? Or?
No, 1 year. Yes, one use.
One use.
And we throw it out because, again, we're sterilizing things. So we had one of our behavioral health nurses got this great idea. And she said, you know, and she's a seamstress, and so she started creating these bags. And she started working with some of our behavioral health patients as part of their activity to build these bags. And so now you can come to our gift shop and you could get a blue wrap bag. And it's part of our green initiative. We've done sleeping bags for the homeless, and we've done smaller bags. They have white bags that's when you turn them inside out. And so we are keeping this out of the waste stream. But it was done by a staff member who just said, hey, I got a great idea. So we have two other things I want to share. We have a couple of things we actually gotten patents or in the process of patenting. We have what's called an Izzy box. And this is a way to distribute, for nurses to safely distribute insulin. So there's 4 types of insulin. It's a multi-use vial. And so what was happening before we created the Izzy box is the nurses would get an order for Humalog for Mr. Smith. They'd take their multi-use vial, they'd put a needle in, give Mr. Smith his 50 cc's, and then they had to figure out what to do with the vial. And like they're supposed to hold on to it for the next patient, but they put it in their pocket or they put it on the side, and not always, but enough that it started presenting a bit of a safety issue. And we were getting ready for our Joint Commission accreditation review, and the head pharmacist was running around going, what the heck? Like, there's all these vials around. And they kept sweeping them through. So she came up with this great idea. You know how you go to a service station and you get a key, and in order they don't lose that key, they stick a brick on it, or they stick some large piece of metal. So she went to one of her team members, Izzy, by the way, Isidore, and he took a Dremel tool and he created a brick that we could give to the nurses. He used the Dremel tool to cut out a hole so we could spin the vials and you could barcode it, and now our nurses come on shift. They get all the insulin they need for a shift. They kind of won the safety, the barcode. So this box has been patented, and it's available in about 100 hospitals around the country.
So other people, they all picked it up. It's becoming part of the profession for
and it's
this type of use. It
actually saves money, but really the reason to do this has been patient safety. And then, so another story, and again, this is sort of just how I'm proud of the culture. So we got a 3D printer, and it was Brian Granulotti, the CEO of Atlantic, and I were touring one day. We ran into one of our team members who was excellent at drawing. We just got in this conversation, and he was saying, yeah, I'd love to figure out how to create some stuff on 3D printer. So we went to the Overlook Foundation. They funded us with a 3D printer. We got him set up, and he's started doing some work on the 3D printer. And so I do physician orientations once every other month to welcome new doctors. And we had a new orthopedic surgeon who was fellowship trained in shoulder surgery and wrist surgery, hand and wrist surgery. And so he just quietly listened to my describing the facility and describing how we support innovation. And I described the 3D printer. And he just quietly went off and found the 3D printer shop, which is buried in our 3rd floor, not easy to find. he went up to BJ, who's the technician who runs, he's the guy who runs the 3D printer shop, and said, well, if I get you a CT scan of a shoulder, can you make me a model of a shoulder? And that's what we have here. So he indeed did get the digitized version of the CT scan. They put it in a 3D printer, and voila, they came up with this model of the shoulder. Well, so why is that useful? So Dr. Erickson, who was the physician involved, actually did two things. One is he used this little model to kind of feel his way. So when he actually went into the shoulder, he knew what he was going to feel with his hands. So it was a way for him to simulate some very specific things. He also took it with the patient, said, here's how I'm going to fix your rotator cuff. And he was able to use it as a teaching tool. So I love that story because Dr. Erickson just kind of heard this idea, went off and did that.
You know, we spend so much money on R&D, research and development, and here you have 3 examples of just people working on staff with an idea, putting it into practice, and at the market level.
Yeah.
It's fantastic.
You know, and then there's a couple of innovations that have come to us from community members. And so, so Claude Fusco came to me, I don't know, 12 years ago. And Claude, I don't know if he's ever heard me tell the story quite this way, but Claude came and said his wife had passed away after a 2-year bout with cancer. And Claude had had a stroke. And Lieber, who was our foundation director at the time, said, you know, Claude and I are going to come talk to you. And I was like, okay. And so Claude came to me and thanked me, told me how we took great care of his wife and took great care of him, and he was doing well, and he wanted to give back somehow. And so, so I said, great, what are you thinking about? And he said, I don't know, but I got some friends, and, you know, I'm willing to ask them to help fund something. I said, okay, you have anything in mind in particular? And he didn't. And I thought, okay, I chalked this up and said, it was a delightful hour. I got to hear how we deliver great service, which is always better than hearing the opposite. And I figured I was never going to hear from Claude again, but we had a delightful time. But I was wrong. Claude calls me up about two months later, and he said, you know, I have a friend, his girlfriend's up at Northern Westchester, and they have this thing called a caregiver center. And this is Claude talking, and as I thought about this, I was thinking, you know, there was 2 years that I was taking care of my wife and not paying much attention to myself, and no one was taking care of me. And, you know, maybe if someone was taking care of me a little bit more, maybe I wouldn't have had a stroke. And so that was a pretty compelling story. So we just all got in the car, went up to Northern Westchester to say, well, okay, let's see if we can figure this out. And we went up and saw what they were doing. We said, okay, we could do that. We could do it a little better. We had some ideas right away about how we could do it better. And so we came down. We took half of our library so we could put the center right off the lobby. And we had very generous support of the foundation, and the Glassers led the way, and so it's now the Glasser Caregiver Center. And a year later, we opened up the Caregiver Center. And so what is it? Well, so it is a place that supports the family. And we get about 150 families. Pre-COVID, we had about 150 families a month that come and use it. It's a respite. It's a quiet space. We have a social workers there, so she can do some unofficial counseling. We have some peer groups to help provide support. We have food. We have computers. There are a couple of side rooms if there needs to be private conversations for the family. So, and the letters I get from family members in terms of gratitude is just amazing. So, fortunately, Claude Fusco came to us with this idea. We were able to execute on it.
Just another example, though, Alan, again, not coming from a psychologist, a health psychologist, coming from a citizen who's been through life himself, saw what the repercussions possibly could be, and want to do something for it. No, we've been very, very lucky. And again, you mentioned before, originally Overlook was a community hospital. It's gotten bigger. The medical center becomes more regionalized, but it's still very involved and very community specific. And I want to bring that topic into what happened. The major crisis during your career, during anyone's career as a healthcare provider, healthcare servicer, was this pandemic.
Yep.
So things happened, okay? All of a sudden, you get hit with this foreign type of pandemic. You don't know how to treat it, how to handle it. Tell us about some of the things that happened with Overlook and what you were proud of that you noticed through your staff and also your community.
Yeah. So greatest challenge of my career and probably the most rewarding challenge of my career. And quite honestly, I was very inspired by our team and how they responded. So to put things in context, the typical census at Overlook's 310 patients on an average day. We can scale up to 400.
These are beds.
Patients staying in the beds,
Yep,
right? Right. So it's on outpatients. At the height, which was mid-April, well, actually, I'll go back. So first week in March last year, we had the first patient in Atlantic Health System who came in, took care of him, sent him home, and I was like, all right. You know, like we were starting to hear all these horror stories out of New York, but it was like, okay, well, we took care of this. So I went to my team and said, all right, well, we're going to get more, but this wasn't so bad. So how are we going to take care of 10 patients? About a week later, we start seeing more patients. So this is like mid-March now. But by April 15th, we were seeing about 40 admissions a day and had 309 COVID patients in the hospital. Now, fortunately, we had the foresight to stop elective surgery before the governor told us to do that. And so we had only about 45 non-COVID patients. I remember the Commissioner of Health had a call with us probably towards the end of March saying, you know, you need to think about tripling your critical care capacity. We have 40 critical care beds and staff for 40 critical care patients and equipment for 40 critical care patients. And she said, well, you need to be thinking about a plan to triple it. And I was like, no way. Well, we got pretty darn close. We actually got up to 109 critical care patients. And so we had to be very innovative, very creative, figure out how to utilize resources in a different way than we were used to, and not have a lot of time, you know, and still have tons of unknowns. So one of the most inspirational things that happened is, so if you think about it, we got critical care doctors. They're used to taking 10 patients, maybe 12 patients. Well, now, so that covers 40 beds, right? Well, now we got to figure out how to cover triple that. So we figured out if we could have two other physicians, could be residents or, well, could be any physician, supporting the critical care doctors, we could multiply their ability to take care of patients. And as we were talking through this model, one of the cardiologists was in a meeting and said, well, I can be a super resident, you know, I'll support the team. And then we had general surgeons and we had colorectal surgeons, and they all agreed to basically subordinate, like be gophers in some ways for the intensivists. And that just set the tone of like saying, hey, look, people are going to do what they have to do to be creative and innovative. And that broke a lot of barriers down.
Did you get to the point where you were overwhelmed and you had to turn people away?
So we almost never divert from our emergency room, and we did go on diversion for maybe 48 hours. And part of what was going on is that the hospitals to our east, Newark, Elizabeth, Linden, those hospitals were getting overwhelmed, and so we were seeing a lot of patients from those areas come over, and we still were. So we did have that 48-hour period. We got a few things worked out, and we didn't go on divert any other time except for that very short period of time. It's something we just don't do, and so we did do that for a very short period of time. We were able to, we got very short on ventilators at one point. We were trying all sorts of things that weren't working. Like, you've probably read in the newspapers, people putting 2 people on a ventilator. Well, that didn't really work. Or using anesthesia machines for a ventilator. We actually tried that on 1 or 2 patients, and it worked on one, but maybe we tried it on 3, it worked on 1. We realized that was not a solution. And this was the time the state, so I went home on a Friday with about 2 ventilators left, and boy, that was nerve-wracking. But our corporate team was great at calling colleagues around the country, and we got ventilators from Maryland, we got ventilators from Emory, the state came through with a batch, and by the end of the weekend we had I wouldn't call it surplus, but we had about 20 more than we needed.
Alan, we out here in the public started to hear that if you went on a ventilator, there was a great chance you weren't going to survive. Was that a truism?
So I would say, we've had a chance to look back now, and you had you had about a 50% chance. So chances aren't good, but it wasn't. I do think there's this sense it was a little bit of a death sentence, and I don't know that I don't believe that was the case. But if you went on a ventilator, it was a high likelihood that you might not come off.
Where was the turning point? When did you start to feel that the medical profession started to treat COVID a little differently when people were being admitted into the hospital?
So I would, it's interesting. We had to learn really fast. And one of the observations before I answer that question is we really had to act like a startup in many ways, because we didn't have a lot of information. We had to make decisions fast, and we had to make decisions that, there were many times where I told staff, okay, they would come to me with a solution. I was like, that makes sense, go do it. And we'll check in tomorrow and see if it's working. And if it's not, we'll fix it. And, so it was much more of this iterative making decisions in an environment with a lot of unknowns.
A lot of trial.
There was more willingness to be trial and error, and we didn't have a choice. And so the innovation speeded up. And so I think, sort of come back to your question, medical profession was sharing information really fast about what was working. So all along there was new things that they were identifying. So we participated in a number of trials, and some of those drugs turned out to be incredibly effective and turned people's lives around, and some were promoted by the president that didn't work. I think one of the things that the physicians learned really quickly is, if this goes back to your ventilating question, if you had a patient who was ventilated and on their back the whole time, that was much more problematic than if you could flip them over. So we created what we called proning teams, who worked on keeping patients on their stomach and kind of continuously flipping them, so it took pressure off the lungs, and that turned out to be a really effective thing. And then we learned that early on. So I think there were things we learned early on. I think the drug regimens, there were some that worked on a handful of patients, and what was really hard to tell for the physicians is they'd see a drug work on and a patient get better, and they didn't know if it was a drug or just luck, or just that person's course of care. I think the things that really worked are the monoclonal antibodies, and those really came out in the fall. November. So I think we learned a lot really fast. I remember listening in the summer, because the summer things sort of died down here. I remember listening to, the rest of the country was starting to see this and trying to figure it out. But they were doing the same. I remember seeing the head of infectious diseases for one of the big hospitals in Texas on CNN one morning, and he was describing stuff we had learned, 4 months ago, just because it had just happened so fast. So, but I think the monoclonal antibodies, and certainly, the vaccines are a miracle.
Yeah, they certainly have been.
They really are. Well, and it's a real testament to the science in this country.
And we're sitting here in this studio, nobody's wearing a mask, we're all vaccinated, and we're confident. Alan, I'll tell you something that did work also, and I'd like you to kind of expand on it. I saw in these local communities, grassroots, people getting involved, seeing what can we do to help out. there's so much admiration for, especially for the frontliners, the nursing
Right.
people, the ER people, those
Yep.
physicians, staff, anybody involved.
Yeah.
And people wanted to genuinely contribute.
Right.
What did you see? What did you learn from this?
You know, there were just a lot of things the community did was great. So Flag was great. I mean, they worked with the restaurants who were having a hard time. They couldn't stay open, so that was a great group. They came up, paid the restaurants for meals, and then those meals came for our staff, and that enabled people to kind of keep focused and told them how much, and this is no trivial thing, how much the community supported them. You know, we had people come wanting to help with PPE, but the truth is we really had to buy most of that, and we were fortunate as a system to after the first month to really ramp that up very quickly and had a good supply on. But I do remember one donation came where they created this plexiglass box for anesthesiologists to do resuscitations, and they were thrilled. I mean, you know, because it was a way to protect the healthcare worker, and somebody had like machined this thing in their shop someplace, which was phenomenal.
It was.
I think, you know, just all the outpouring of support was people coming up and doing drive-bys and clap-outs. Folks just understanding that we couldn't have visitors.
I'll tell you one thing, Alan. I mean, there was more food at the doorstep of Overlook Medical Center and a lot of the other hospitals, but
Yes.
especially Overlook.
Yes.
You know, people did what they thought they could best contribute, which
Yeah.
was just really it was, as you and I talked about before, the pandemic brought out the best and the worst, but we saw a lot of real good.
Yeah, and I would, from my vantage point, I saw a lot of the best. You know.
It's good stuff. But you know what, Alan, again, knowing that you will be stepping down after this long reign in the profession, I'm sure you'll do other things afterwards. We may touch upon that. I wanted a lot of this interview to be about you, but typical in Alan Lieber fashion, you talked about Overlook Medical Center because that's just the way you are, and that's what comes first. You know, I know you're very modest, but you're also very respected. You know, Alan, I've met your wife. You have a son and a daughter. Your hours can be very, very challenging at times. What was that ride like to have for them during these years?
Oh, yeah. So you know, God bless my wife. You know, she just was incredibly supportive, and she was able to carry on with. She's a tutor at the community college, Bergen Community College, and a spin instructor. And so she was able to carry on doing, well, she really couldn't do spin, but she was able to do tutoring and also find other ways through our synagogue to help people in the community. And so she was very involved in that. And she was just incredibly supportive and just.
And not only then, but also throughout your whole career in this long run.
Oh, absolutely. Yeah.
Yeah.
No, she's Alice is an amazing
And your
partner.
And your son and daughter, Alan?
Yeah. So you know, they had to do their own. They had to make their own adaptations. You know, my son in particular was a little anxious about everything going on. He works in the health system, and so he had to sort through a lot of things. We couldn't actually see them for a very long period of time until we were vaccinated. You know, so we were a tight-knit family. We stayed together. We did a lot of Zoom calls to check in on each other and keep supporting each other. Yeah, so now we are blessed with being able to spend a lot of time together. So that's been great.
That's great. I know that you've had a great family all these years, Alan. As you wind down your career, you look back, and I know it might not just be one thing, but you know, oftentimes we're asked, what are you most proud of? And you know, I'm going to look at you and ask you, what are you most proud of?
Yeah. Let me just go one more family thing. So, so my mom, who's 89, or going to be 89 in July, actually did get COVID, and she got it in April. We brought her down to Overlook, and the team took great care of her. So I got to see it from the other side, and God bless her. She then she went through a gallbladder problem, but God bless her, she's back at assisted living, and you know. The fact that she's made it through has been inspirational for the rest of us.
It's a tougher breed, Alan. It's a tougher generation. You and I have laughed about that.
Yes. So, you know, so what am I proud of? you know, certainly in terms of my family, so one of the things we've done at Overlook is thought about our why, right? And I think this is true for Overlook, but it's certainly true for me. It's to make a difference. And I think my whole family is like that. Certainly my wife is, and my kids are, you know, like we are about doing good things for other people. And the fact that all 4 of us are like that is, you know, probably the thing I'm most proud of. In terms of Overlook, it's a great place. You know, one of the reasons why I'm comfortable leaving is it's got a great culture, and there's just a lot of strength there, and I really hope there's a family feel. You know, we have 3,900 employees, and it's a family feel, and so I really hope that continues there. I think we've talked a lot about innovation, and I really hope I'm leaving a legacy of innovation. And I should mention one other thing, because I think this has become much clearer to me as like I'm reflecting back, is we've had just such great support from the foundation and from the community to be able to do things. And you know, what that's enabled us, it's actually given us the ability to take some risks, because many hospitals are running on razor edge margins. And not that we're on huge margins, but the fact that we know that the community's been there to support us has just given us more room to make some mistakes. And so the community's been a big part of creating what I hope is a legacy of innovation.
Well, Alan Lieber, I'll just say this. During your run at Overlook Medical Center, we, the community, have seen such innovation, such growth, but even more so, as you said before, a spirit of comfort, acceptance, safety. And I want to commend you as president during this period. Again, you were well received and so well liked, and I want to congratulate you on your great run. And I can't tell you how much I enjoyed talking to you today, Alan.
Well,
So thank you for coming in.
yeah, well, thanks again. I thank you at the beginning, and I'll thank you at the end. It's, you know, it's been a great career at Overlook, and it's been helpful. It's been wonderful reflecting on that with you.
And you have many years ahead, Alan, so
Okay,
congratulations. Appreciate it. And thank you very much for joining this special show with Alan Lieber, President of Overlook Medical Center.